Good afternoon, everyone. At the outset, I would like to thank the Cardiovascular Society of India, the Heart Failure Association, the Organizing Committee, and the European Society of Cardiology for giving me this opportunity to present on my work for the last 26 years, integrating clinical practice with research and community programs to improve cardiovascular outcomes. I'll give a brief recap of the research and community program which I've been doing for the last 26 years. As I call it, the art and practice of medicine, which would in future would be my autobiography, my professional autobiography. The art of practice of medicine, creating awareness on heart health, conduct clinical research, teaching and training not only the medical professionals, the future medical professionals, but also the community. During the last 26 years as a solo practitioner in non-invasive cardiology in my hometown Warangal, I have done a little work. My research interests include coronary artery disease in women, which I presented an abstract at the World Congress of Cardiology in 2010 in Beijing. Coronary artery disease in the young, which I presented in 2012, the World Congress of Cardiology at Dubai. 2014, I presented a clinic-based tobacco cessation program through telephonic counseling that was presented at the World Congress of Cardiology in Melbourne. And some of the other topics like consanguinity and congenital heart disease and recent ACC, the impact of left atrial volume index in predicting atrial fibrillation in HCM patients, and the prevalence and incidence of familial hypercholesterolemia in acute coronary syndrome patients that was abstracted as a co-author in the ACC 2025. Pertaining to this topic, the focus on heart failure in this present conference, I'll present the work on some of the important studies which I've done for the last few years. Heart failure, Warangal Heart Failure Registry. This is an unpublished study which I presented at the AHA 2017 annual sessions. The sample size is 1900, predominant male predominance in the study. The EF at the first visit was significant, it was 31%, and common risk factor was hypertension in the subjects, and associated comorbidities like CV and CKD, and even the family history was found in few patients. I found that my obsession with left bundle branch block, the predominant LBB was found in significant number of patients, and which are around 14.37%, and significant LV dysfunction, heart failure with reduced EF, was found in moderate to severe LV dysfunction was found in nearly 80% of subjects. Coronary disease was found in nearly 56%. Significant CAD was found in around 6-7% of subjects. And majority of them had medical treatment. Equal number of patients underwent PCA and CABG in this study. Now, what is important in my study is, though the sample size is 1900, one of the important things which I note in my research is, or any research in our country, in particular in what we have been doing, is the number of subjects with whom some data, and entire data is not available for all the variables in the study. This is one of the limitations in the studies which we have been doing. Of interest, I found mainly we found the event rate in the subjects of Warangal heart failure, where nearly out of hospital cardiac arrest was found in significant number, 206, nearly 81% of them. That exemplifies the importance of prevention of cardiac arrest in all our heart failure patients. The particularly training, apart from following whatever the guidelines discussed in this conference, the training the family members of those with high-risk heart disease, particularly heart failure in CPR, and creating awareness on cardiac arrest in CPR is the most important thing. In-hospital cardiac arrest was found in 18%. So average period of survival in these subjects with Warangal heart failure was around 5 years. The second study which we did was I submitted in the ACC Middle East in Jeddah in 2018, is the prognostic factors in adults with left bundle branch block. This is Dr. William Jogby, to whom I presented my work. again, male preponderance was noted. Average age or the mean age in all these studies, Warangal heart failure study or this LBB study, the mean age was around 57 or 60 years around. Female, and again the survival, mainly in this study, we noted the event factors, the event rate in the subjects during the Kaplan-Meier analysis, both the Warangal heart failure and the LBB study. Significant LV dysfunction was a risk factor for death, and those with higher EF at first visit had a lower risk for death. Again, we found some other factors. This is an ongoing study, even which I will tell later on. The more after that, my obsession with cardiac arrest grew actually, sudden cardiac arrest, particularly out-of-hospital cardiac arrest. And the first paper on out-of-hospital cardiac arrest which I submitted was in Mexico, World Congress of Cardiology 2016. This is not my clinic cases, but the anecdotal reports of cardiac arrest reported those who attended my clinic. It was the other papers, the WACAR study, Warangal area out-of-hospital cardiac arrest registry, and then the observation study of media reports of cardiac arrest, and the recent CSI, last year, I presented the observation study of cardiac arrest, which occurred in my clinic actually. So, coming to the World Congress of Cardiology 2016 abstract, again male preponderance, the mean age of cardiac arrest in this study was 57 years. There were no gender differences. Majority of the subjects, 123 subjects of cardiac arrest reported by my patients who attended my clinic. Because in our routine practice, when some of the patients attend to our clinic, either when one of their family members or friends or some relative or office staff have a sudden cardiac arrest, they come for cardiac evaluation. That prompts them for a cardiac evaluation. So when they come like that, I have collected the data from them using a data sheet. But the main important study, which in the next study is, in this study, I did not follow the Utstein template. For information, Utstein template is a foundation for clinical research in out-of-hospital cardiac arrest. It's a template which we have to use either in-hospital or out-of-hospital cardiac arrest, either adult or pediatric. The Utstein template is a foundation stone for clinical OHCA research. And this I did not follow in this. Age group between 40 to 59 years and above 60. And the time of death was also studied in this. And the conclusion of the study was those above 40 years and with symptoms and risk factors prone for out-of-hospital cardiac arrest were seen in this. The median time of 10 minutes between symptoms, onset of symptoms, and out-of-hospital cardiac arrest. What does it suggest? It suggests that all the first responders, particularly 80% of the cardiac arrests occur in the residential or the home. So the first responder being a family member, all those with high-risk heart disease should be, and those with risk factors, their family members, as per the ACC and AHA guidelines of 2016 for prevention of sudden cardiac death, all of them should be trained in CPR, and awareness on cardiac arrest should be created in them. So this is a very important thing. So the other major publication from our side, which is a collaborative research between me and the University of Illinois, is, as a principal investigator, the WACAR study, the epidemiology of cardiac arrest, risk factors, and knowledge of cardiovascular disease in a low-resource setting in India. That is the WACAR study, the Warangal area out-of-hospital cardiac arrest registry. This is the first registry on OHCA in India. This is a regional registry. And there is a prospective observational study of OHCA from January 2018 to December 2018. And mainly all the cardiac arrests which attended my alma mater, MGM Hospital, was studied in this. Out of 1,106 cardiac arrests, the non-traumatic cardiac arrests were segregated, of which 814 subjects had cardiac arrest of presumed cardiac etiology. We studied the demographic, clinical, and resuscitation characteristics in them. What is important is, this is based on, we called it a modified Utstein template, because apart from the basic Utstein template, here I studied basically the risk factors and cardiovascular disease in them. The study pattern is importance is, though we gave the data collection forms from the casualty and emergency department in MGM Hospital, data collection was difficult. So subsequently, all these 814 subjects we called them telephonically for the missing data. Despite that, there was some missing data in this study. So data collection is an important thing in research in particular, in general, and in this study in particular. The importance is this data set, the Warangal area out of hospital cardiac registry got the best data set award by Elsevier. The reason being, any of us doing research should conform to the fairest principles, and Elsevier has given the recognition based on these fairest principles, which this study conformed to. The fairest means findable, accessible data, interoperable data, and reusable data. Based on this, this got the data set award. The Wakar study had majority of the male subjects, median age of 60 years, mostly in residential areas, and inadequate resuscitation data. Majority of them had risk factors. Past history of heart disease was found in 25.23%. The important factor in this study is ischemic heart failure was seen in around 17%. Ischemic heart failure was seen in 76%, and non-ischemic heart failure was seen in 17%. So majority of them had ischemic heart disease. So out of the cardiac arrest happened, the type of heart disease, mainly heart failure of ischemic origin, was seen in the majority. So, and the comorbidities also were seen. Respiratory, renal, and stroke incidence was high in this study. Preceding symptoms, duration of symptoms were studied. Now, the other important study which gave a glimpse of OHCA epidemiology in India is the media reports from 2001 to 2019 with a search item of cardiac arrest. We studied in the English newspapers the cardiac arrest incidences. Now, why this is important? Of two reasons. One, it gave a glimpse of cardiac arrest. Even apart from the VI people who have a cardiac arrest, even anecdotal reports of somebody, because any cardiac arrest which is reported in the media, it will catch the public attention. Like someone in a temple dying suddenly, or in a religious place, or someone at a polling station, some politician inaugurating. So this gives the role of media health literacy in creating awareness on cardiac arrest and CPR is very important. So that recent study is the last 26 years cardiac arrest which happened in my clinic. Though the sample size is very small, 49, from 2006 to 2016, I had an inpatient in my clinic, and the response time when someone gets admitted, the average period of hospitalization is not more than 1 day. At that time, we did not have the interventional cardiology practice in Warangal. So, and when the primary and secondary care I was just giving and managing them, and because I was just staying in the same premises, and of them, apart from those patients who had within my center in the clinic, in the hospital, while hospitalization, majority of these cases were walk-in patients. Like they enter the clinic and they have a cardiac arrest. Of them, majority of them, and all of them survived. Those walk-in patients, that data was submitted in the CSI, and we are going for publication probably by next year. The survival was very good in these cases. Now the Warangal, the latest study, which is an ongoing one, is a Warangal Heart Registry study, where we are studying the, earlier I was not having the data except few samples, like those with atrial fibrillation, LBB, and coronary disease, heart failure. I used to maintain the data. But 20th April 2020 to date, all the patients who attend my clinic, we are scanning and keeping in the cloud, Google Drive. And until September 2024, around 19,377 ECGs, 19,650 are patients, around 9,200 ecos, and 3,879 treadmill. So I am going to analyze on 34,270 patient interactions, because both the ecos and TMTs are done by me only. And this we are going to analyze by next year, the risk factors, presentation, and the type of cardiovascular disease. Subsequently, I'll just present the community cardiology work, because whether it's the clinical research which we do or the community programs which we do, they will impact the outcomes. Research that helps me in auditing, doing a clinical auditing and prescription auditing, like in the heart failure conference, we have discussed so many guidelines. Whether really I am following the guidelines prescribed or not. That had made me more wiser and wiser, and I think I'll implement that in the clinical practice and translate into the research, so that how far I am implementing them in the patients. Community cardiology programs from 2001, the World Heart Day, Tobacco Day, and these things were conducted. This is there in the website. Then the Know Your Heart program, which is an awareness program, which I titled as Health Education and Awareness in Rural Telangana, that was recognized by the World Heart Federation in 2014 as an innovative program in the developing countries. This is one of the books in Telugu, in the local language. And of late, from 2009 onwards, I started focusing on cardiac arrest, particularly CPR training and creating awareness on cardiac arrest. We started the National CPR Challenge campaign, the National Initiative of CPR Education, and recently we started the Project Heart. We have trained the NCC cadets, NSS, high school students, college students, and public. So everyone in the society, apart from the family members, should be trained in CPR. The Project Heart is High School Education Awareness for Resuscitation Training. This is one of the programs in the indoor stadium in 2012, the program. And this is some of the NCC cadets and recent Project Heart event. So the take-home message is, whether it is you or I, as far as the implementation of the guidelines or screening for cardiovascular disease or risk factor management, the iceberg concept, because we are only seeing the tip of the iceberg in our routine practice. I think to make it a perfect one, which might be difficult, but we need to have, the message is need for clinic-based and hospital-based registries, because epidemiology will differ between a clinic, secondary center or a tertiary center, either it's a government one or a private one. So the epidemiology will differ. There is a need for proper follow-up of all of our patients, need for screening for risk factors and cardiovascular disease. Population studies are also important, and ultimately we have to create awareness, access, and affordable care for creating an accountable set. Lastly, I would tell, just because during all my days, there were some inspiring instances. This was the first instance where, as an intermediate student in residential junior college in Nagarjuna Sagar, I had an opportunity to interact with the Nobel Prize winner Crick in 1981. And recently, I had another opportunity to interact with Professor Mario Capecci, who was attending the RP meet in Atlanta, I think. He's a professor of genetics and a Nobel Prize winner in 2007. I had a very brief interaction on WhatsApp. Ultimately, the thing is, I'll conclude by telling about the Warangal Heart Registry, which is an ongoing one. We have more than 20,000 patients in that registry. The aim of the study is to have an epidemiology of cardiovascular disease in my routine clinic setting. I interacted with the pinnacle organizers in ACC, but ultimately they refused, saying that they're not offering the pinnacle registry to other than US guys. So ultimately I started my own registry, and pinnacle, because I had an interview in 2 years back during the COVID time. The second objective of this is survival analysis of event rate in all my patients. Because we do not, that's very important. And event rate or survival analysis, we know only when there's a proper follow-up. So in all the studies, or we have to agree that sometimes the proper follow-up of the patients will not be there. So I employed telephonic counseling, a telephonic way of contacting all these subjects, and it's a very big task for contacting the lost patients who are lost for follow-up. That is the second objective. The third objective of this study is, I am a co-supervisor for an engineering student, NIT Warangal, in creating an AI and machine learning models for cardio. The aim of the study is to predict cardiovascular disease in these patients. If we give the ECG, echo, and TMT and angiographic data, they have to predict the cardiovascular disease. 1. 2, to predict the type of cardiovascular disease. And lastly, to predict the sudden cardiac arrest risk in them if we give the clinical data. So maybe the day will come when we will employ a machine learning model, just look at the face of the patient or apply a machine learning model immediately when they come to the clinic. Maybe one of you can win a Nobel Prize. Thank you.